Cecilia.
Right, okay, thank you. If I can, it has gone 9:30 now, so if I can welcome everybody to the Shropshire Health and Wellbeing Board meeting. Thank you for those present in the room, and also welcome as well to those we've got joining us virtually. So welcome to this meeting of the Health and Wellbeing Board. I'm Councillor Simon Jones, Chair of the Board, and I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to see this meeting and hear the audio. We will start with members in attendance. Please can you state your name, role and organisation. Don't forget any members who may be attending. Oh, that's an in brackets message for me, which I just read out. Right. Okay then, so if we can do the creeping death, as I say, my name's Simon Jones, councillor. I'm portfolio holder for adult social care, public health and housing, and I currently chair the Health and Wellbeing Board.
Rachel Robinson, Executive Director for Health, Wellbeing and Prevention in Shropshire.
Claire Parker, Director of Partnerships in Place for NHS Shropshire, Telford and Wrekin.
Right. Hannah Thomas, Community Wellbeing Manager for Public Health.
Lead Consultant in Public Health, Shropshire Council.
Lynn Corley, Chief Officer at Health Watch Shropshire.
Ellie Mason, Head of Joint Partnerships, Shropshire, Telford and Wrekin, NHS and Shropshire Council.
Councillor Kirsty Hurst, I Portfolio Holder for Children's Services and Education, Shropshire Council.
Cecilia Mockley, can't remember who I am now, because this is the wrong. Actually, that's an old-fashioned name tag. But I'm the portfolio holder for communities and health, with particular reference to the integrated care strategy.
Okay, Val Cross, Health Wellbeing Strategic Manager at Shropshire Council. And it's on.
I'm Michelle Dulson, Committee Officer for Shropshire Council.
And if I can also ask the those attending online. So first of all, we've got Simon Whitehouse.
Simon Whitehouse, yeah.
Morning all, apologies can't be there in person this morning. Simon Whitehouse, Chief Exec with NHS Shropshire, Telford and Wrekin.
And then Ben Holland.
Morning everybody, I am the Health and Wellbeing Strategy Implementation Manager at MPFT.
Nina Gregg.
Hello, I'm Nina Grix. I'm the Workforce and Business Development Manager at Shropshire Partners in Care. I'm here as a substitute for our Chief Officer, David Crosby.
And Alex.
Hi, Alex McClellan, Public Health Intelligence Manager for Shropshire Council.
And we've got Elliot.
Hi there, Elliot Roberts here, Community Wellbeing Outreach Officer for Shropshire Council.
Yeah, I think that's everybody. So welcome to everybody. Apologies have been received from Patricia Davis, Superintendent Stu Bills, David Crosby, being subbed by Nina Grix, Jackie Jeffries and Tanya Miles. Is Sonia? No, I thought Sonia was representing Tanya today, but not. Okay, item 2 on the agenda, disclosable pecuniary interests. Members are reminded to disclose any pecuniary interests in any matters to be discussed which is not included in the register of interests, and leave the meeting prior to the matter being discussed. Are there any disclosures at all? No. Good. Item 3 is the minutes of the last meeting. So we'll now move to approve the minutes from the meeting held in September. Right, we've all got a copy of those. So to summarise, follow-up action and notes of highlight in these minutes include a request for an update on the ICP draft strategy, which is being presented by Nicola Diamond today, a cost of livings update request, which is being provided by Emily Fay today. And with regard to the severe mental illness, the SMI and complex needs paper, the chair said that he felt there was a role here for the NHS around integration and how to bring physical health services and mental health services together in a more equitable way, along with a role for the NHS and its broader partners, e.g. social care, local authorities, voluntary community sector, in order to get a better outcome for the population that was served. Concern was expressed about how vaping was being made to look attractive to children, and more work was therefore needed around this messaging. This is happening, and the Task and Finish group has met to take this forward. Updates on action will be reported back to the board. I move that the minutes of the Health and Wellbeing Board meeting held on the 8th of September 2022, as circulated with the agenda papers, be signed as a correct record. Can I have a seconder? Thank you, Claire. So we're all happy that those are an accurate set. It's been moved and seconded, yeah? Right, thank you. So I'll accept these minutes as a true record unless anybody indicates differently. Item 4 on the agenda is public question time. We've received a public question from Mike Richardson, Shrewsbury Friends of the Earth, in relation to the air quality update item. Val Cross will read out the questions and I will read the response. Okay.
Thank you, Chair. So the response is from Toby Pearce, the Public Protection Officer, Environmental Protection, Health and Prevention Directorate, Wellbeing and Prevention Directorate. So there are 3 parts to this question. Part A, there is no mention of this 22 ASR or in the 2021 ASR of the Zephyr monitor results. Where are these, please?
The response to that part of the question is Earth sense Zephyrs are commonly referred to as low-cost sensors. The information provided by the monitors is therefore indicative and not reference level monitoring to be reported within the annual status report, the ASR. During the initial grant-funded project, data was displayed on the public-facing portal in October 2021. It was decided not to renew the public-facing portal due to funding requirements and the change in role of the monitors, whereby they would be rotated for specific projects and not solely fixed within each AQMA as previously. The Council has currently retained 2 EarthSense Zephyr units within an active service and calibration contract. It is anticipated that these will be used for short-term monitoring such as before and after highways interventions, school street closures, and for screening potential exceedance of standards and newly identified locations. Reporting of this data will vary dependent on the purpose for which it is collected. If specific information is required for certain or all locations, the Council can provide the information it has available on an individual basis by contacting Environmental Protection or using the Freedom of Information request process.
Part B to this question is 1. Would the officer give an indication of levels at these places so far for 2022? And has any traffic monitoring been undertaken?
As we're still within the 2022 monitoring year, we cannot yet provide annualised figures as they will be reported in 2023 in the 2023 ASR. This work and analysis will most likely be undertaken in early 2023 once the December results are received.
What are the plans if the North West Relief Road does not get built?
The Council is currently planning Air Quality Action Plan, AQAP documents. These will consider upcoming scenarios for each AQMA, and it is assessed as if it is assessed as being necessary, purpose further interventions to reduce emissions in both Shrewsbury and Bridge North AQMA. In Shrewsbury, this work will consider scenarios and interventions both with and without the implementation of the North West Relief Road.
There is no mention of action in Bridgnorth. Why not?
Reference to AQMAs within the 2022 ASR should be taken to refer to both Shrewsbury and Bridgnorth AQMAs, unless stated otherwise. Work is progressing in Bridgnorth, and officers are working closely with the Highways Department to maximise any potential air quality benefits from strategic work in Bridgnorth. This is closely related to the current AQAP review project. Further updates will be provided to the Health and Wellbeing Board, Shropshire Council's website, and within future ASRs as this work progresses.
And in summary, given the lack of effective action since the current NO2 limits became legally binding in 2010 and which have been illegally exceeded since then, will the board please agree at this meeting to demand positive real action and firm plans within deadlines? Without plans, lobbying for external funding is extremely difficult.
Officers would draw both the board's and the public's attention to recent changes to the Environmental Act 1995, which was introduced from the 1st of May 2022. These specific changes have been underlined in the below text for clarity. The 2021 Act introduces new Section 83A to the Environment Act 1995, which strengthens requirements in respect of local air quality action plans, AQAPs. Under the new requirements, AQAPs must set out how the local authority will exercise its functions to secure that air quality standards and objectives are achieved in the area to which the plan relates, and how standards and objectives will be maintained thereafter, rather than a requirement only to work towards achievement. Local authorities must also specify a date by which these measures within the Air Quality Action Plan will be carried out. Air quality partners are required under the Act to collaborate with the local authorities in developing and carrying out air quality action plans. In essence, the above new changes have introduced more stringent requirements on the development review action plans, AQAPs. The current AQAP review project is carrying out a data and intelligence-led assessment of both AQAMs in order to develop the most effective plan that can feasibly be implemented. Further information of AQAP review project can be found within the November update to the Health and Wellbeing Board. And I can just say that the written response will be sent to Mr. Richards and placed on the council's website with the meeting minutes.
Okay. I think we've agreed, Sam, that we will ask for a report to be brought to the January Health and Wellbeing Board and be presented as a report. Thank you.
Thank you very much. Sorry, I missed that.
Nicola Diamond's not here, so Claire Parker's taking the next slide.
Okay, thank you. Right, I've just been informed because Nicola Diamond isn't here, Claire Parker will be taking the next presentation. So if I can invite Claire to take this item, please. Okay.
Thank you, Simon. I'm going to assume that committee members will take the paper as read. The first statutory integrated care partnership meeting happened at the beginning of October, and actually yesterday, hot off the press, there was a strategy workshop meeting. The first draft of the integrated care strategy has to be submitted by, I believe it's the 5th of December, and it was a really well attended workshop from both Shropshire, Telford and Wrekin. A good mix of attendees at that event, some really interesting information around inequalities, not just health inequalities, and looking at how we shape the mission and vision and the values of us as a system, and then what the delivery in place will look like for both Shropshire and for Telford. I think there was a lot of energy in the room. There's a real will to take this forward. And I think the biggest takeout for me was particularly from Health Watch, I'm sure Lynn will say it herself, and other members of the workshop to say, we've had these discussions before, now's time to get on and do it. So that was very much the takeaway message of yesterday. But there were some other members of the of the board that were there. So it would be really good to hear their feedback, and I'll take any questions on the paper.
Thank you. Yeah, Rachel.
Thank you. Yeah, so I'll alongside Claire, I'll pick this item up because myself, Nicola, and Liz Norks have been and Lynn have been some of the colleagues who've been involved in the kind of development of the strategy. We've set up a subgroup to make sure that we do develop the strategy to ensure that we meet the deadline for the end of this year. And I think what's really important, and it's highlighted in the paper, is the purpose of the strategy. And I know we discussed this at the last Health and Wellbeing Board, but this is absolutely, we're not starting from a blank canvas and a blank sheet. We've got a really well established health and wellbeing strategy here for Shropshire, but also the developmental work in Telford. And that's, as Claire said, the conversations we had yesterday, we brought those together, looked at areas of common ground. Both health and wellbeing boards, both SHIPs and partners were invited to that meetings and formed that part of that wider ICP partnership and engage and stakeholder group, which is absolutely going to be critical to taking this forward. I think what was, as Claire said, there was a real energy in the room yesterday. That is the start of a conversation because of the timescales in terms of publishing this, and it is not started from a blank sheet. That's why we're really keen that this is interim, that we'll continue to develop it, and we absolutely, and I think it says there in the, in the legislation that actually we've got to engage with people around this, and I think that came across yesterday as being really critical, but also that it should, as Claire said, feel very different. And there was a real conversation around the way that this should feel different, the way that we're working needs to be different, and if we're going to deliver our strategy, we absolutely need to work in a different way, and that needs to be front and centre of how we work. This is about setting out our vision and ambition for everybody in Shropshire, Telford and Wrekin to have improved quality of life, health and well-being. And so it needs to be very ambitious, and I think there was a feeling that we needed to get the basics right, but also that all the needs that we've identified in both our areas, and there's a lot of overlap, they need to be our priorities that we need to take forward collectively. So the next steps are very much to take the learning from yesterday, to continue to engage with a wider membership, because not everybody could be at that meeting, to develop the strategy. And obviously we won't have a health and wellbeing board in Shropshire before the draft strategy is published, but we'll make a commitment to ensure we're sharing that and come to the next meetings to continue to engage to develop that strategy. Is currently where we are at the moment. It's absolutely really important, fundamental, a lot of energy in the room, and obviously that wider engagement. So it was just to sort of update people, and I'm sure other colleagues were involved in that and would want to come in. But it really a positive starting point. This is about getting it right for our population.
Thank you, Rachel. Yeah, I was going to sort of throw it open now to questions. I have Penny.
Thanks, Joe. Just to say, that idea that we're not starting from a blank sheet of paper, but which is true, and we certainly did a lot of work pre-COVID on the long-term plan, and there's probably things in that long-term plan that we can look at seriously around whether or not it is still relevant, and probably many things are. But I think what was different was the commitment from across the board yesterday from a wide range of partners in the room, and I think that maybe is something that the plan can really focus on, is how using that commitment to work together and pool resources and use our resources more wisely, but also that kind of working in partnership and how important that is. So I think that's where the kind of, for me, the difference was yesterday, and something that I think we need to build on as a local area.
Thank you. Cecilia.
Thank you very much, Chair. Yes, it's a very interesting session. There were a lot of different interests represented, it seemed to me, and there was a general agreement that we've really got to take this forward. And the question is not so much what we need to take forward, but how we take it forward. And I think that that's where a huge amount of work is going to need to go in. But I picked up very much that there is very much a willingness to engage, from all sides, bearing in mind that there were a lot of different interests represented at the meeting yesterday. And I felt that it actually was a really positive session. Thank you.
Thank you, Cecilia. Yeah, Lynn.
Thanks, Chair. I think I just wanted to say that for me, it's important that as a system, we are able to articulate for the public how they will see improvements, what difference it's going to make to their experiences of health and care and their outcomes. And I'm not sure we're there yet, but as soon as we can articulate that, I think it'll help everyone working in this system know what they're aiming for. So that's just what I wanted to add.
Thank you. Salient point. Thank you. Do you want to respond at all?
Thank you, Chair. I think absolutely. I mean, it's great that everybody felt that it was positive. I think the piece of work that we're doing around what outcomes look like and what impacts, that was very, very clear from the conversations in the room. And I think that's a slight shift, if I'm honest, from conversations that we've had before. So I think, as Rachel says, this is the start of the conversation and the engagement, notwithstanding we have to submit the first draft, but we'll keep going with it.
Yeah, so Simon.
Thank you, Chair, and didn't want to go back over old ground, but I think really helpful suggestion in terms of Penny and Rachel around how do we bring together JSNA health and wellbeing strategy with the previous long-term plan submission. But I think Lynn's point was on point on this, which is we have to get to a point where we write a strategy that articulates a sustainable health and care system and what that means for the local population. I think this has to feel as though it's got the traction. There's always a risk for me that we'll get a national template of it. The plan needs to look like this. Actually, I think we need to hold firm on this and be really strong to say this has to articulate clearly for our residents and for our staff and workforce what this means and what this will deliver and what this looks like. It's an opportunity to pull together the learning from COVID, the data and the population health information that's there, the previous plans and strategies, get it into one place and set that overarching framework that then we've got collective responsibility to deliver against. So I think Lynn was absolutely on point in terms of that challenge to us. And I know, Lynn, you and Barry will continue to hold us to that because I think that's really important.
Thank you, Sam. So, Rachel.
Yeah, it was just to make a comment, and I've received apologies. Sorry, just to note that from Nicola. Well, let's pick this up. Yeah, I mean, I think it's just to reiterate that point. We had lots of conversation about the importance of the outcomes. That we talk about working differently, and it wasn't just us working differently. That it felt very different for our population and for everybody involved in it. And I think it was, and we needed to make it feel that way. So even in looking at the outcomes, it wasn't about we will do, it's about how we do this together. There was a real wanting to shift in the language and the culture and the way that we're working, so that we are having a loud voice locally. We are being very clear, and I think as Simon very well articulated, not being done to. So that's why it's important that we push back and make sure that we do engage, get that wider engagement and really make it so it feels different for our population. At our last joint host, we were challenged very strongly on that actually this needed to feel different. As you said, as members said, we've been here before. This is an opportunity to do things differently. And so in the way that we set the outcomes in our ambition, we really need to articulate that as together. That is us and our population. So I think I just think that's absolutely right on, just to emphasise that, and that's going to be. And it's how we hold ourselves to account, and that to make sure that we deliver that for our population.
Thank you for that. Certainly, my experience from yesterday attending the meeting was that it's the first sign of true partnership. You know, that we're actually going to become a true partnership between all sides. Right. If there's no further questions, I'll accept the recommendations provided, unless members indicate otherwise, which are that the board is asked to note the detailed contents of the report, to note the statutory requirements for ICBs and local authorities as core members of the system-wide ICP to develop an integrated care strategy, to note that this strategy must be informed by the work of the Health and Wellbeing Boards and through engagement with local partners and communities, and to note approval of the terms of reference of the Shropshire, Telford and Wrekin ICP. We're happy to note those. Thank you. Moving on to the next item on the agenda, which is item 6. Shropshire Integrated Place Partnership SHIP update. So if I can invite Penny Basin to take this item, please.
Thank you, Chair. This paper is really just by way of assurance to the board, as the Shropshire Integrated Place Partnership, otherwise known as SHIP, reports into the Health and Wellbeing Board as it does into the Integrated Care Board, and to assure the board that work is underway to deliver both elements of the health and wellbeing strategies as well as that of the integrated care system and the priorities within the system. So again, I'll assume that people have read the report. I suppose just to highlight again that those priorities for SHIP are children and young people, prevention, healthy weight, healthy lifestyles, mental health, community capacity and resilience within the voluntary and community sector, local care and personalised care, supporting primary care networks, integration in one public estate and tackling health inequalities. The report highlights that over the last few months, the key areas of focus. It also highlights some risks to the system. One of those I'll just pull out, which is around falls. So the falls response within the system. So the SHIP has noted that at times people are waiting once they've fallen for a long time for support and help. So there's specific pieces of work going on now within the system to deal with that by a collection of the SHIP participants. And so we're making good progress and we're working closely with partners on that, and we'd be happy to come back to the Health and Wellbeing Board in a few months to let you know how that's moving forward. And again, the report just highlights some agreed actions to provide assurance that the integrated care part or the integrated place partnership is delivering on the actions. On the priorities. Thank you.
Fine, thank you, Penny. Does anybody have any questions or comments for Penny? No. Right. Thank you. Right, so moving on then to the Joint Commissioning Board Better Care Fund, BCF. Can I invite Penny again to take this item, please?
Yes, thank you. So normally this would be Assistant Director Laura Tyler, but she's had to give her apologies today. It's a busy week in the system. So again, the Better Care Fund, as you know, comes to the Health and Wellbeing Board for approval every year. Better Care Fund planning template was provided to us from NHS England in the summer for a return in September. The timing didn't work out with the Health and Wellbeing Board to approve prior to submitting the report and the planning template, unfortunately. So it is here now to gain that approval. It is still within with colleagues in NHS England looking at. We have had from our regional colleagues within NHS England, they have forwarded to the national programme with a recommendation for approval of our plan, but they are also waiting to hear from us that the Health and Wellbeing Board has approved the plan. As with with previous years, our key priority areas within the Better Care Fund are prevention, admission avoidance and system flow or delayed transfer, so ensuring that people are able to move out of hospital and into their place of home as soon as possible. So there's key activity happening, and that's collated within the not within the planning template, but within our narrative document. So the board will note that the narrative document holds quite a lot of information about a range of projects that are happening around the system to ensure that we are preventing ill health to begin with. We're also preventing admissions to hospital, and we're working with the system around system flow. And the report also highlights that there is a mismatch between projected issues into the coming year around our demand. So demand continues to increase, and we need to look carefully at what's available around funding for the demand that we are expecting in particular for hospital services, admission avoidance and delayed transfer system flow. So that is a risk that's highlighted within the report. And therefore, the report asks the board, the recommendations are to approve the plan, but also to approve additional joint work within the system to look at that and how we can support that through pooling budgets, through looking more broadly at how we can resource support for our system.
Thank you. Thank you for that, Penny. Does anybody have any questions or comments for Penny?
The one thing to note is this year we were asked to produce a demand and capacity template, and just just so that it's clear to the board that that template itself is not going to be assured. The template we had to include as part of our return to NHS England. However, it was more to support us in our demand and capacity modelling rather than something that NHS England will approve. So that was an addition this year, but so it is as part of the papers, but it's not something that for the board to approve.
Thank you for that point. Yes, Simon.
So helpful, and had cited this previously, and Penny, you picked up on it, because when I looked at the demand and capacity report, the profiling doesn't appear to reflect winter. So when I looked at the numbers and I looked at the demand and capacity modelling piece, I would have expected to see a distribution curve that would have reflected a change in demand and capacity over the winter period, but I couldn't see that model through in terms of our assumptions around activity during a seasonal period.
I think, yes, Simon, and I think there's more work for us to do on that. So it was something that was new this year. There was a lot of scratching heads because it also, there wasn't a lot of detail around the definitions of intermediate care and how we were meant to apply and which parts of our programme we were meant to apply to the template. So there was, I think what NHS England are going to get is quite a lot of different assumptions around that template. So yes, you're right, there's more work for us to do, and I think that's something that perhaps the working group can pick up going forward, because the demand and capacity modelling is so important.
And Chair, if I may comment, so that I think that's really helpful and was what I anticipated, Penny, but useful to hear that articulated. And I think the importance of the BCF this year, undoubtedly, but our planning for next year and the planning for the demand and capacity and how we make sure we best use the money that sits in that pot to really support that flow in the system and make sure that we've got absolute clarity on what that's delivering and what that gets and what that means for local residents, I think is going up the agenda. So what started as something that we knew was a piece of work we needed to put in place, and we tried to get our heads around how best to use it, I think is increasing in its importance over the coming period.
Yeah. I think so.
Yeah.
Oh, wait.
Okay, Claire.
And thank you, Penny, for all the work, because I know it's really detailed on the BCF. I think taking Simon's point about the amount of work that we're going to have to do going forward as a partnership, we've been talking about rebasing the joint commissioning group that sits underneath the Health and Wellbeing Board. I'm kind of taking the words out of Laura Tyler's mouth because she's not here today. But we've talked about using that group to make sure that we're understanding the detail within the Better Care Fund, that we're able to report both into the system, the ICB, and through to the Health and Wellbeing Board. So that's the plan, to take that detail forward and really kind of understand it, the definitions, making sure that we're meeting the metrics, and then some of that demand and capacity monitoring as well. So that'll happen through that group.
Penny.
Thanks, and I guess I would say this, but also I think as a system around that pooling of the budgets, we also need to really make a significant focus on prevention. So whilst there is prevention within our Better Care Fund, and we're very wedded to that, because we would be in a much worse state if we didn't have that prevention. We also need to look at actually how do we make collectively a better focus on how we stop people going into hospital in the first place. So so I just wanted to make that point. It isn't all about system flow. Sorry, Simon.
Well, apologies, Chair, if I could just come back quickly. I would say that is fundamentally about system flow, actually, because it's a key component and a key part of it. So we need to get that bit right as much as we need to get the hospital flow right. I would accept that there's two different aspects of that. There's the in-hospital piece and there's what do we do with our population.
Yes, Rachel, go on.
I'm going to have to come back on that, because just to support absolutely what everybody's saying, but particularly what Penny said. And actually that came out in the workshop yesterday as well, around the importance, well, of two things, not only of actually doing things differently, not just focusing on getting the stuff done that we're told to get done, but actually doing a good job on that, which absolutely we need to do. But we're only going to change this if we really do look at the whole system, get upstream, and we've talked about that. And I say it every single meeting, so I'm completely broken record, but I'll never stop being a broken record. Along with Penny on this, you know, it's really, really important. That came out yesterday, but also the use of resources, and actually that we need to agree what the priorities are and align resources to those priorities and be really clear, and to have that vision and not just do the same old, because we'll end up dealing with the crisis over and over again. And that again, it's just to re-emphasize those were the conversations we were having yesterday, and the need to look at that and bring resources together around that.
Thank you. Right, thank you. So there are no further questions. I'll accept the recommendations provided unless members indicate otherwise, which are that the board is asked to approve the Better Care Fund plan for 22-23, agree a Better Care Fund working group as part of the governance arrangements with membership from the Integrated Care Board, Shropshire Council and members from provider organisations as needed, and to note the work of the Better Care Fund review and Better Care Fund audit, with a further detailed report to be submitted at the January Health and Wellbeing Board. So we're happy to accept those. Yep, all in agreement, that's fine, thank you. So now we'll give Penny a rest, and I'll invite Val to take the item on Healthy Lives update.
Thank you, Simon. So this is just a brief update on Healthy Lives, which is the prevention programme of the Health and Wellbeing Board, and this has the focus on preventative health. I'm not going to, as others have said, go through the whole paper, although it's short, as I presume people have read it, but just want to sort of highlight the key priorities that Healthy Lives is looking at. It's sort of, if you like, the delivery arm of the Health and Wellbeing Board and SHIP, part of the delivery arm. It's got a good joint membership, and it's to ensure that the health and wellbeing strategy is implemented. It's all part of that as a system to do that. And the preventative programmes include social prescribing, healthy weight and physical activity, food insecurity, trauma-informed approach, mental health, killed and seriously injured on roads, and health inequalities. We've had an addition into health information for people who do not speak English as a first language, and a really important addition, particularly in with our health inequalities work. So we meet monthly, and I just want to stress really this isn't a reporting shop. There really are, there's a sense of energy with the meetings, and the members do genuinely show commitment to wanting to move things forward. We have people come in and talk about different activity that's happening, which are sort of highlighted in the recent meeting activity. So, for example, Lincoln Davis, and so somebody will come in and will say, right, okay, what can we do, right? Well, and different services will, say, oh, you could come to this, or you could get involved with that. This is work we're doing. We could link that. So it's all that linking and trying to move things forward for people at the end of the day. So we've got just having a quick whiz through the recent meeting activity. You can see there that the group supported a small but successful funding bid for Shropshire Libraries. Health Watch give regular updates on their surveys and reports, and we cascade those and hopefully see how we can move things forward with information that's found. And then we have our other regular partners at Energise and Marches Energy, MEA. So, it's all about linking and enabling the understanding of what services can offer and how we can support each other. And also we had a really good presentation from libraries about the speech and language work they're doing, and obviously that closely links with the speech and language work as part of the Health and Wellbeing Board priorities for children and young people, and we will be bringing a paper back in April on that to give an update, but also linking that library work. So one of the key things from the paper is that we've got good representation from local authority partners and our voluntary and community sector, but we do have a gap with our health partners at the moment, and this isn't to be critical or to moan, it's just, it is a reality. And if we want to move together as a system, we really need a really good representation across the whole system on this, so we can link things. We did have a really good rep from Telford and Wrekin, I want to say CCG, it's not CCG, NHS, but that person's recently been diverted to a different health specific group meeting and can't commit to being a full-time member, and that is a real loss because that link was fantastic in terms of PCN, primary care networks, a really good link there, and things are really moving forward. And the concern, I guess, is that we're going to start missing things, that opportunities are going to, be lost there. So we've got Bernie here today who chairs that meeting. So I get that the plea really is, can our health partners think about who could come along and be a representative on that? The meetings are an hour and a half every month, but they go really quickly and they are very proactive, and that we do a lot of work on there. It's not just a talking shop. So the other item on there is the work that's happening for health information for people who don't speak English as a first language. And this was something that came from a meeting we had to try and look at the agenda setting for the HOSC, Health Overview Scrutiny Committee, and the Health and Wellbeing Board, and something as well that Lynn had raised from Health Watch. And so a small group have met to discuss this initially. You can see the things that have emerged on there, that I think it's key that it's not clear about what translation services are across the system. We know they're there, but it's not clear and joined up as to how that is, and we recognise that's something that really needs to happen. And also web-based information that's consistent in another language. So suggestions are a mapping exercise and looking at good practice locally and nationally, regionally, and maybe we need to have shared web-based information. So conversations have taken place recently to see if this work could be done with a subgroup of the Quality and Diversity Systems group, but I'm just waiting to hear back more about that. So if I take a breath for a minute, the recommendations are that the board are asked to know the contents of the report, and members from health are asked to actively consider who from their service could attend the Healthy Life Steering Group, and you can contact myself or Bernie. And also there are different translation services across the system, as I've just said, but not clear what these are and how people using the services will be able to access. So clearly leadership is needed for this across the system, and it is a risk for the board to discuss. And that concludes. Thank you.
Thank you. Any questions or comments for Val? Yes, Lynn.
Thanks for that, Val. I suppose I was just reflecting on the conversations that we'd had about information in other languages. This is partly from my teaching background, but I think anything we produce for people who speak other languages, who have come to this country from others where their systems are different, any of that information that we produce will be useful for our own populations, because I do think we've got a very complex system of health and social care. A lot of people don't understand it, so they tend to rely on certain parts of it because they're not aware of the other parts that exist. And so I would just encourage any of that work to be done across all languages, not just for people who speak other languages.
Thanks, Lynn. I agree completely. I think we hear a lot about health literacy and people understanding health information and navigating the system, and it's very complex, so yeah, thank you.
Yes, Penny, and then I have Claire.
Thanks. Yeah, thanks, Val. Healthy Lives does some fantastic work, so thanks for bringing it here. There were just a couple of things I wanted to pick up, and one is it's just around the prevention agenda. Is so not just the ICB, but like our provider partners. So just what we were saying around the Better Care Fund paper, actually as a system, we really need to be investing in prevention, and that includes kind of who can work with, how can we work collectively on that. So if we can sort of think about who else in the system from our provider partners as well, who can attend and think about prevention and how we embed some of the activity, thinking about making every contact count, thinking of a whole range of things within their organisations, but working collectively with us. And the other thing was around the language. So we've heard quite a few examples of where things, and it really addresses inequalities. So Shropshire has, I would say, not done very much work in the past on with our diverse population, because it's always been seen as somewhere that doesn't have a very big diverse population. But actually, to me, it doesn't matter how big your diverse population is. People exist, and therefore they need to be supported, and will speak different languages, and will have different cultures, and will have different understanding. And actually, it's up to us to figure out how we can support those people in the best way so that they understand us and work really hard on that. And I think we need to do a lot more than we're doing now. And it is about having things translated, but it's also about how our workforce actually are able to communicate with the people that they come across as well. Or if we, so we've heard examples of a letter being written to a Bulgarian family who couldn't read the letter, and then the child didn't attend school for 6 months. That's not okay. None of that's okay. So we really need to kind of get to grips with this, I think, as a system. It's not one of our responsibility, it's all of our responsibility. That's it.
Thank you. Claire.
I was just going to pick up the first point to say that we will most definitely find somebody that will engage. I'm not sure the person that you had was necessarily the right person. We will make sure we get somebody equally enthusiastic to engage, even if it's not me.
That's much appreciated. Thank you.
Ben.
Yeah, similar Val. Send us the details and we'll see what we can do. We do also have translation services in the trust. And there's quite a significant piece of sort of equality, diversity, inclusion work which is taking place in Shropshire. So there's some links to make there. But let's pick up a conversation outside of here.
Thanks, Ben. Much appreciated again.
Thank you. Right, have we got any further questions? If there are no further questions, then I'll accept the recommendations provided, unless members indicate otherwise. And I won't go through what the recommendations are again, just repeating what Alice just said. So we're happy to accept those recommendations. Yeah. Thank you very much. Right, now change your face again. If I can invite Bernie to take the item on the equalities plan.
Thanks very much, Chair. I think Val is going to kindly share my slides for me.
Sorry, it's just gone a bit haywire, my system.
Don't worry. So, I mean, I'm really pleased to be actually sharing the inequalities plan with you today. I think many of you recall it's probably a year or so since there was a commitment to draw together an inequalities plan. And since that time, Val and I have been working hard with our colleagues across the council, within the NHS and others, to pull all the required information together. And I think you will appreciate from those who've gone through their packs, which I assume you all have, it's a very long report. So I just intend to highlight some key points from the paper, if you like. I think the process of developing the plan has been collaborative, and in many ways our conversations have raised awareness of inequality and health inequalities, and the wide range of actions that are needed across the system to sort of close the gap, if you like, in achievements across our communities. And obviously a lot of what I'm going to talk about builds on what was discussed yesterday, and also, what's been discussed in this meeting so far today. So next slide, please, Val. So this slide summarises the contents of the report, so the bullet points at the top, and really emphasises the fact that the plan couldn't possibly document every single sort of action, intervention, work programme that is in place and that will impact on inequalities. But you see there in the bottom set of bullet points, these state the sources, if you like, of the priority areas that are included. Next slide, please, Val. So there is a lot of detail in the report on the factors that underpin inequality and health inequality, and the intersectionality, if you like, of the different factors that predispose individuals and communities to health inequalities, and really how the overlapping of those different factors can really sort of intensify the negative impacts of any one of the characteristics, if you like. And I think it's also important, and I know Rachel often says this, we really do need to emphasise the role of the wider determinants of health and how these drive health inequalities. So next slide, please, Val. And, moving on to the evidence, really, Sir Michael Marmot, an international expert in equality and health inequalities, and he has clearly documented the evidence, around the outlining the factors, if you like, that need to be addressed across the life course to improve the health of the whole population. And they are sort of stated there. And importantly, he advocates proportionate universalism, whereby services or interventions are provided universally, but with more sort of support, enablement, to individuals or communities who are going to be in greater need of help, but who are also less likely to access that support. Next slide, please. And this slide sort of illustrates this really. So the concept of proportionate universalism shown really there in the top right figure, the equity box. And you will see the first box there, top left, equality. That illustrates how giving equal resources to all does not really give equitable outcomes. And, the equity box really demonstrates that some individuals need more support than others to achieve the same outcome. So next slide, please.
Oh, sorry.
It's okay. So this slide shows the extent of inequality across Shropshire based on a range of different indicators. And the index of multiple deprivation there, the top line, IMD. Now that indicates that in general, the Shropshire population is less deprived than the England average. But we know that IMD is not great at measuring rural deprivation, which disadvantages areas like Shropshire in multiple ways. I think the key point to note here is that whilst as a county, Shropshire fares relatively well, there is significant variation within Shropshire. And the top table, you can see a range of stats that just basically show that. But also you can see that whilst we compare favourably against the England average for these statistics, there is a range in outcomes across the electoral wards. So I'd like to focus on the bottom row there because it's an important statistic, preventable deaths aged under 75. And across the county, you can see that on average, there are approximately 14% less deaths than the England average, but the range is from 52% lower mortality in Corverdale through to 60% higher mortality in Sundorne. And then the bottom table shows that across the county at LSOA level, there is a 5.5-year gap for men and a 3.5-year gap for women in healthy life expectancy. So I think these are the gaps or the differences that we really need to close. Next slide, please. just like to share this one because this slide illustrates how rurality impacts in terms of access to housing and services, which is one of the domains within the IMD score. And on the basis of the measures within this domain, many of Shropshire's LSOAs are within the most deprived in the country. But this domain attracts less weighting than others within the IMD score. And so this is one reason, of course, why IMD doesn't wholly reflect rural deprivation. Next slide, please. So this sort of now moving on really to how we tackle this inequality. And these are the principles that really should underpin all of our work. We need to recognise the complexity of the challenges facing our more deprived communities. We kind of really need to value the insight of those with lived experience and also sort of be intelligent and evidence-led and clearly co-produce solutions. Next slide, thanks Val. So our inequality plan adopts a population health model, so the diagram there on the left, and acknowledges the wide range of influences on health outcomes, particularly, again, the wider determinants of health. Next slide, Val. The plan pulls together existing work programmes, adopting a very similar format, if you like, to the service delivery plans included in the Shropshire plan that my council colleagues in particular will be familiar with. And the priorities within the inequality plan wholly interface with and support delivery of the Shropshire plan and the associated target operating models. And I think likewise the plans interface with the NHS operational plan, which is obviously equally as important. Thanks, Val. So here from really more from an NHS perspective, we have the healthcare inequalities priorities, which are sort of expressed through the core 20+5 framework. So that is for our services plans interventions to focus on the core 20, the most deprived quintile. From an ICS perspective, a larger proportion of the Telford population fall within that quintile. Then there are the 5 clinical areas, which you can see illustrated on the slide. So continuity of care in maternity, health checks for those with severe mental illness, chronic respiratory disease, early diagnosis of cancer, and hypertension case finding. And then there is the plus, which is optional. But for our ICS, we have agreed we should look at rurality as having a sort of an independent and significant impact on inequality. And amongst other things, we hope to work with other partners to build the evidence base around that, so that in future the unique needs of rural areas can be addressed. I think that's all on that one. Thanks. So the plan includes high-level details relating to what I think is 63 different programmes. Val might have counted them, but I think it's 63 different programmes or service areas. And every one of them is important. However, I'd say based on discussion with colleagues across the system, some overriding priorities emerge that I don't think perhaps will surprise any of us. Obviously, the cost of living crisis will have a damaging impact on health, and more so for rural communities. And I know that there's a paper next agenda item on this. And likewise, smoking. I mean, smoking accounts for more than half of the difference in risk of premature death across social classes. And death rates from tobacco are 2 to 3 times higher among disadvantaged groups than among the better off. And, it is a cross-generational issue. And again, I know this is a current issue. It was on your agenda at your last meeting. So I suppose basically you can see that the issues sort of bubbling to the top in this slide, the negative consequences of digital exclusion. These were frequently highlighted. as was rurality and particular hardships it generates. And again, I can see that from the minutes that came with the meeting pack today, these issues were discussed at your last meeting. So, you know, investing early in the life course and more general early intervention is recognised as, you know, key priorities amongst others sort of listed there. Next slide, please. Thanks. So the plan has included, towards the end of the plan document, a sort of some key areas of focus or factors that are really sort of, I think, considered to be particularly relevant from a Shropshire perspective, many of which, of course, have been mentioned. But I think it's worth, you know, they're worthy of pulling together and of some emphasis here in terms of, you know, these really are important to us. On we go, thank you. And the report itself includes these high-level recommendations. And I think, you know, just to draw your attention to these, they are, you know, they're included in the main body of the report. But I think, you know, perhaps particularly the bottom bullet point, recognising our shared collective responsibility to reduce inequalities is what we're going to need, you know, for success. Then it just in next steps. It's all right. Val's eager to get to the end. So in terms of next steps, we'll be sharing the plan with the Population Health Board, with Cabinet and full council. And of course, we are already making progress on our recommendations. And then my final slide is just to, you know, the recommendations that are included in your report for this board are stated here, which I'm sure you will have already noted. But that was all I was intending to say. And I'll be very happy to take any questions, points of clarification. I don't know whether I should invite Rachel, because this is something Rachel holds dear to her heart, whether there's anything you think I could have emphasised more or said any more, then please say.
Thank you, Bernie, and I guess not to say more, I think you very eloquently pulled this together. But firstly, to say a massive thank you. You know, as you said, this has been a significant piece of work that you have absolutely led, and working with Val and pulled that thought together. You know, it's no mean feat, and I think what this does is puts at the heart, firstly, in the Shropshire plan, in our health and wellbeing plans, and in the integrated care stuff, the work we need to do around inequalities, not just health inequalities. We've been very clear on the need, if you want to tackle health inequalities, you need to tackle inequalities and how these are linked. So I think for me, this is really, really important for many reasons. One, in terms of the breadth that you've outlined, this is not one person's job. This is actually, and it's recognised as a sort of system-wide commitment to really tackle this. Inequalities, as we know, as you've said, has come to the fore in COVID, particularly, even more so than ever before, and now in the cost of living crisis. So there's never more of an important time to work collaboratively together to address this. And what you've laid out is a plan that is very comprehensive, that shows everybody's role in that. And I know that there's other things we could bring in, but the key areas we need to focus on, and also sets out on our commitment and my commitment and the team's commitment to how we will monitor that and hold, I think really importantly for this board and for scrutiny and for the ICS, it's how we'll hold everybody to account to make sure that we deliver this, because we know that it's the right thing to do. First, commitment in our Shropshire plan, as said, within our health and wellbeing strategy. So it's a huge thank you for first of all, as you said, not to yourselves for pulling it together. Absolutely support that commitment, and I'm happy to commit to that here, and we'll continue to bring that through the board, but also to thank everybody who's involved, because everybody will help deliver this. And I think, as you said, the process of going through this has helped people to understand that their role and how important all of that is. So just to thank you.
And just to add to that, you know, to say, you know, we have worked hand in glove with in Claire's team, really. I think Tracy Jones in particular really worked so closely. We called ourselves the Three Musketeers.
Right, thank you. Now open it to questions and comments. Claire.
This stuff is fantastic, isn't it? This is really exciting, and yeah, thank you to you and the Three Musketeers, Bernie, for that work. I think this is a thread that's gone through all our conversations this morning, actually, about what we need to do across the county. I'm really interested that when we start to design the delivery of services and through our neighbourhood teams and what we deliver at place, that we really concentrate on not creating further inequality by some of the services that we try and deliver. We had a really good conversation through the workshop yesterday, talking about some of the work around improving healthy lifestyles and actually how that had created a bigger divide across the inequalities, because those that understand and can pick up those services and those messages do, and actually it just creates a bigger divide. So really getting into the nub of where we need to put the services and what those services look like to tackle this, I think starts to get into some really interesting space. So thank you.
Okay, do we have any other questions? I can't see any hands up on screen. Yeah, Cecilia.
I would just like to say that I really welcome this piece of work. I think it's great, and I'm looking at this particularly from the point of view of rural health and inequalities. I'm a rural member, as you probably know, and I'm acutely aware of the difficulties, particularly in accessibility of access of getting health care services. I would just like to recommend for you that you keep in touch with the Rural Services Network on this, because they've done a huge amount of work. And there is there's the Lincolnshire Rural Health and Care. I can't remember its exact title, but I can certainly let you have it. And they've been doing an enormous amount of work on rurality and the adverse effects of rurality on health. So it just might be helpful for putting more information together for you.
Yeah, can I answer there, Chair? Because I am in very direct dialogue with Lincolnshire, with the director and a clinical research fellow there, and I'm sort of working on a kind of a potential proposal that we can take through the Rural Services Network and perhaps through OHID and NHS England, if we can find the right people to talk to try to bring people together to really build that evidence base. Because I agree with you, this thing about access and the difficulty of demonstrating that access is lower, because there is this sort of belief that, well, it's lower because they're all healthy and well. And it's actually how you have to correct for need, and then how, so it's complicated, and I think we need more people working together on it. So I'm really, sort of right with you where you're suggesting.
That's very good. If I could just add that this business of inaccessibility works both ways. It works in terms of help coming in as much as the need to access, for individuals to access healthcare. And that's the bit that actually tends to be forgotten until you try to set up a programme of delivery into the rural areas, and you discover quite how difficult it can be. So I'm just thinking in terms particularly of your neighbourhood teams, that it's quite an issue that I would suggest.
Yeah.
Okay. I've got Ben, you've got your hand up.
Thank you, Chair, and thanks, Bernie. Really interesting thoughts there. Just I guess a point of reassurance to some extent that the health inequalities agenda is quite embedded in much of the work going on in mental health at the moment. We know that is a group which is more exposed to inequalities than most of the population, and we're on a bit of a journey with that, really, I suppose, just to acknowledge that we understand that access as one aspect of people experiencing health inequalities is something we're very mindful of. It's embedded in the mental health transformation, but there's a long way to go with that, and just understanding that problem through our clinical record system, for example, is quite difficult. But just to also say, I suppose we also need to think about what the role of provider trusts is in that sort of wider conversation, not just about providing care, but also how are we going to contribute to that broader conversation about people's wider holistic needs, which are so important to their well-being and big drivers of their need for healthcare in the first place. And lastly, we do have an ongoing piece of work going on across the trust, which obviously would incorporate the Shropshire Care Group around health inequalities, and it'd be good to sort of make sure that that's factored in, I suppose, to your thinking.
Thank you.
Yeah, thanks very much, Ben. I was just going to say, I think, but I might be wrong, but I think it's not quite clear to me quite where inequality sits, sort of like at executive director level within the, I know Claire carries the portfolio, but within the ICF. But I had thought that each trust board was supposed to have an inequalities lead, but I might not be right on that. I don't know. Do you think that's right, Claire?
Yes.
Yeah. So that's something for us perhaps to follow through on, be clear about.
Okay, right. Do we have any other questions? Sorry, Penny, I've got your name down here. I wasn't ignoring you.
Yeah.
I
I just
was,
wanted to say, kind of building on the kind of conversation about rurality. Well, two things. One is that the report and the is such a great resource, and we've used it multiple times already to apply for funding and do different things. So thank you, Bernie and Val, you've done a fantastic job. But the second one is just to say that I think what we could tie into that and will help is the work that's going on around the Joint Strategic Needs Assessment, which we'll hear about in a bit, but particularly around rural access. So we're hearing a lot of, so some of our team are going out to very rural communities, having those really real conversations with people about why they don't access services. And that's a whole combination of transport and availability of services and, and then entrenched ideas and culture. So there's all kinds of things in there. So there's something that we can really use the JSNA to kind of help us understand our population and what we need in those rural communities.
Okay, thank you. So if we have no further questions, I'll accept the recommendations provided unless members indicate otherwise, which are that the board is asked to note the contents of the report and the details included in the inequalities plan, including the recommendations made in section 17, appendix 1. Endorse the inequalities plan, recognise that the success of the plan in reducing inequalities is a joint system responsibility that all partners are committed to delivering, and advise on timescales for reporting progress in reducing inequalities and health inequalities across Shropshire. We're happy that we accept those recommendations. Yep, all in favour, right, thank you. So moving on, we're actually ahead of time now on the schedule. So if we can now move on to the cost of living crisis. So Rachel, if I can invite you to take this item, please.
Yeah, and so apologies from Emily today, and I know we've also had apologies from Jackie, but so they're not both here, but I feel I absolutely again just want to highlight the fantastic work that Emily, the social task force, all members of that, including Jackie, who sits on this board as well, are doing around cost of living help across Shropshire and for Shropshire residents. This is absolutely a partnership work. You can see all the partners who are involved in this. It has been since March. I know we've brought updates to this board, but I think it's right that we keep bringing updates through to this board. This is so rapidly moving, akin, I would suggest, to COVID and the response to COVID, and it changes on a daily or weekly basis, it feels at the moment. I wasn't going to talk through all of the slides, but I'm happy if we kind of whiz through them, Val, because things are moving very quickly. So what we've been doing as a task and finish group is firstly constantly reviewing the data that's available, and that will change again, as we all know today, probably in about 45 minutes. We'll get a further update, and again later in the year. This is rapidly moving because of the international and national situation. So these figures that we're presenting and were pulled together last week again will move even in the course of a few days. But what we do know is that the impact on our population and the population in Shropshire particularly, but also on businesses, so on our residents, on our communities, and also on our businesses in Shropshire is immense. And we expect that these were the projections as we know for October. We've got an idea of the projection of what that will be in March, and I think we'll hear later today that we expect those costs, for example, around energy to continue to rise. And this just explains in a bit more detail. It's not straightforward to work out what the cap is. It's not necessarily a cap and of 2.5, and that's an average per household. And I'm not technical to go into all the details on this, but just to reflect this and the real impact that this is having, and that there remains a gap, and this remains a gap for our most vulnerable. And I think with the cost of living, particularly, it's a scale of the impact, and so every household, every individual will be affected in some way, some more than others, but it's the actual scale of that, with over half our population living in that low income, and we add to that rural, add to that transport and heating costs, and you can see particularly in Shropshire we have high levels of vulnerability as we head into a really difficult winter. And this slide is really important because that just illustrates, as we're a health and wellbeing board, particularly some of those health impacts, both directly and indirectly, and the impact that will have on our system. So the work that we've been doing, and as said, I guess on this slide, I mean, we saw in COVID the impact that health had on the economy. Well, now we're seeing the impact that the economy has on health, and the two, as we've constantly said, are completely interlinked. And this just illustrates the impact on a scale that we've not seen before. So we're worried about a range of things, from the direct impacts, as we said, on health, on people's, and we've got there, the impact that will have on hospital admissions, on GP appointments. We know that is happening, but also then on people in the medium term, if you like, in terms of the impact of what choices people are making around heating and eating, but particularly, and I know Ben's on the call, around mental health. All of these are really real, and we are very acutely aware of these. So the work of the task force within Shropshire across partners, because again, this is not one organisation's response, this is how we all come together to respond, is absolutely fundamental. So again, I won't go into this. This is the vulnerability index. Shropshire, Telford and Wrekin are in the highest levels of vulnerability, and we will be living with the consequences. So I think probably if we'll go through, you've got these in your packs, and if we go through some of these slides, and perhaps want to focus a little bit on some of the work that we've been doing to support and to help people. And what you've got in your pack is more information on about those, so you can understand that we are building this from an evidence base. We're constantly looking at using data and intelligence to understand who in our population is most likely to be affected in different ways. And so I think if we come towards the end of the slides, what you'll see in your pack is the work that we have been doing. We talked, sorry, just to pause on stigma. We've talked about this a lot. We've talked about this. This is one of the kind of core elements that we've been discussing as a task and finish group, and the way that we respond to the cost of living and the way that we speak to people and understand where people are coming from is absolutely critical to the way that we deal with this. This is not about creating stigma. It's about understanding what this means to people. And some really.
Rachel, sorry, I actually used some of this information yesterday. I think this has been brilliant. I mean, I've downloaded this onto my phone, so it's current, when you go to meetings, the work that's been done, and just the visual element as you go through this. But I found this really helpful at a meeting yesterday about stigma, and I just think it's important that you know that the work that has gone into this is current, and we are using it as counsellors. So I just wanted to highlight that was really helpful yesterday. Thank you.
That's fantastic. Thank you very much. I think it's really helpful. I mean, that's what the task force was put together to make sure we share that. And I think, and it is right. And I know if Jackie was here, she would highlight this importance around how we talk to people around this, the kind of language that we use, the assumptions that we make, and it's not right to make those assumptions. And there's some examples up there in terms of people, the assumptions we make about people being able to make choices, and the choices that people make. And the criticism, probably shouldn't say this publicly, but having been in that position myself, that's I think I've probably said to people before, in terms of my background, and as a child being very much in that situation, actually some of these assumptions that are made about you or your family actually have a significant impact, and that's not the case about the choices that people have. And so we all need to reflect on that and think about that, as this bites and will bite and affect so many families in Shropshire. So a lot of work has been done to make sure that we get the tone and language right around this, and I think it's something we all need to challenge ourselves on, and we should do daily. So just so this is the important bit, and this is the bit with the messages that we want to get out to our communities today, and we need to absolutely be pushing out. So first of all, if you're worrying, everybody's, you're not alone, and know that you're not alone, and know that there's support out there. There may be simple steps that people can take. And you can see some of those, and we've produced many resources to bring that together. So the partnership have worked very strongly to constantly keep updating the resources, to let people know what help is available, to help you not only cut costs, but also maximise your income. And there's help available. It's in one place. It's in the cost of living help website. And I would encourage anybody to go there and get that information. And it's constantly being updated as new information becomes available. So those simple steps are there. But the most important is do not struggle. Doing all that, you're not alone, that we have got support out there to help people. And we have got, and I will probably get in trouble for this, but I'm going to keep pushing some of these messages, but I absolutely want to promote the helpline that's there for people, promote our website, and make sure that people go, if you're not alone, please, if people are worried, and I think that's the messages for the public, but also for partners and also for our workforce to make sure that they access that support. And so we've got the helpline. There's a huge amount of good work that's happening. There's information out there, and this is being pushed out, and you can get it on our website, but also in leaflets being made available. We're pushing those out through local members, through local organisations. So want to make sure that everybody's got that information. The other work, just to draw your attention to specifically, is around the warm welcome. Brilliant. People probably heard, hopefully people heard on the radio this morning, Ludlow, Hands Together Ludlow on the radio talking about some of the services that they've set up. That's just one of we've got over 50 warm welcome sites being run by a wonderful community and voluntary sector organisations, pulling those together across the county, a range of offers in different sites. That's all brought together so people know where they can go and receive just that, a warm welcome. Also pulling in other services where we can, and offers from there, and also some of the council sites. There's a range of community sites, so there's a range of information out and support out there for people, and it's fantastic to hear what everybody's doing. So you're not alone, and that's a point that you can go to just to keep warm, but also to get support and advice. So I just wanted to highlight those, and then come back to Councillor Hurst-Knight's comment around the training. Really, really important, the training that we put on for our workforce, for our communities, for our volunteers. It's been recorded. It was a partnership training that was put together. It's been rolled out, and I would encourage everybody, it's on YouTube, to go back and look at that and make sure that for our frontline staff, but also for others, that it's a really good refresher and a really good pointer through this, not only in understanding where people are coming from, reducing that stigma, but also just letting people know that there's support available. And certainly in this, there's a huge amount. A lot of this is huge, and we know the impact that's going to have, but there is measures that we are taking to reduce that impact together. And I haven't done that justice. Emily would do it much better justice, but I think this is such an important issue, and we'll continue, and I'll continue to work through this regularly. And just thanks to everybody on the task force who's involved in bringing this together, and there's colleagues around the room. I know Susan's called been doing some warm welcome, so it's involved. We've got Hannah and the outreach team. This is everybody is involved in this, and making sure we get these messages out. So just thank you.
Yeah, thank you for that very impassioned presentation. I must admit as well, when I was talking to Emily when she did the presentation at the cost of living, the group, the concerning thing that we heard the other day is the fact that the power companies can switch smart meters onto prepayment at a flick of a switch without telling people, and it's the standing charge, which is so much higher for somebody on a prepayment meter, and so the more vulnerable are on a prepayment meter, and they're having to pay more than the less vulnerable. Right, does anybody have any questions or comments for Rachel? Yeah, sorry, Lee.
Just an observation, really, a couple of things. I think there's always, when we talk about issues around cost of living, there's always an emphasis on families and households. But I suppose that I just wonder how much is done to communicate with people who are single and live alone about what's available to them, because they may assume that most of the support is available to families. And also someone who lives in shared accommodation, and has been on a prepayment meter. I really understand the challenges that people have on that, and I was fortunate enough to get off that meter, but it's extremely unfair that on prepayment that you have to pay more because of who it's set up for.
Yeah, I mean, I think just to say, yes, when we talk about household, but that you're absolutely right, and that includes single households, and we've recognised that you've got many pensioners living on their own. We've mapped out, individual, as you said, individual. I mean, this is the scale of this is huge. So what we've done, and I did flick over it actually, so it's just right to pause on that. Some of the analysis we've done around some of the data and targeted groups that we've been looking at, and then looking at how we target communications to those groups. The information available is for everybody, and it tackles a range of support from, you're right, some is specifically for families, some will be specifically for pensioners, but tries to bring that together in one place. So it's obvious to those on low income or who are struggling, and to make that support available. So you're absolutely right to emphasise that. And again, that comes back to that message. There's things that we can do to help reduce costs and maximise income for people. That's all in one place. That's everybody, because we recognise how many people this affects, and you're not alone. So look at our resources, speak to partners, speak to somebody, and we have got that helpline. I'd encourage people to come and use that.
Yeah. Do we have any other questions or comments at all?
Ben.
Oh, Ben, right, yes, Ben.
Yes, sorry, just quickly, is there any, just thinking about that stigma issue and how perhaps we need to be kind of tackling these conversations? I know that there's some anxiety amongst staff about how they might approach this. Is there a training resource which we could make use of? It's great to see that there is a sort of centralised set of resources we can point people towards, but it's just how that kind of conversation might get managed in the context of like a clinical appointment.
Yeah, I mean, I think, Ben, the information that we've pulled together and certainly part of that training pack, it involved all partners and specialists, in terms of some of our specialist partners as well, in having conversations. I would encourage all staff, frontline staff, to access that training, because I think it's really, really important in terms of the material and explaining some of the context. It does talk about stigma and having those conversations, and it also points people to where there's help available, which is, I know, really important for staff to be able to actually not feel helpless and know where they can signpost people for further information and support. So we can make sure that everybody has access to that link and information, and we can keep sharing that. And obviously, if we've got specific questions, then we can support answering those and signpost them. But I think what my first point of contact, and I know I did take this to the chief exec group as well, was to say we can encourage people to access that training. We can make materials available for just to get people. And it's, for me, it's this again illustrates the importance of us working together around this. This is not just one organisation. We've really come together with our specialist partners and the community involved sector, who are doing a phenomenal job to bring that together. So if I point you to their first, if there's any further questions, come back, and I would encourage all partners to access that and share that with their staff, particularly as we go in to win. This is prevention in action, actually, because some of this is about us trying to get to people as early as possible. And some of the work we have been doing is being able to target particularly vulnerable groups. So where we've got in groups of the population, whether that be families, whether that be individuals, we've also been doing some work to reach out to those groups as well, and contact them proactively to make sure that we get support really early, so people don't end up in crisis. And that's been, I haven't gone into that today, but again, that's been another piece of work we've been doing, which has been really well received, and reaches people as early as possible and points them to all the support that's available. So, and we're definitely seeing that increase in demand already. Sorry, the final thing, because you've started me now, we could talk about this forever. We are developing a dashboard as well, so we can monitor all of those all the work that we're doing and some of those trends. And again, I think it'd be great with health colleagues as well. We can track some of those hospital data that health data that's coming through, so we can really keep an eye on that. And then we can pinpoint where we target action and offer support for people. So I would ask again for everybody to come forward with that, and we can be very proactive here.
It's a shame that your heart isn't in it. Right, if we got no other further questions or comments,
I'll send the link round. I'll send the link round to members after the meeting.
For the training.
For the training, yeah, training.
Right, so if there's no further questions, I'll accept the recommendations provided unless members indicate otherwise, which are that the board is asked to the Health and Wellbeing Board is asked to note the work underway to mitigate the impact of the cost of living crisis on our residents and to make any comments as appropriate. Members undertake to take this information on the cost of living back to their own organisations and consider how the cost of living crisis is impacting both their own workforce and the residents they support. All in favour? Yeah. Thank you. Right, we're back on time now. And we're now moving on to the JSNA update. And if I can invite Rachel and Alex to take this item, please. We will also have input from Penny and Hannah, who is the Community Wellbeing Manager for Partnerships, Community-Led Support and Engagement. Okay.
Brilliant. Thank you very much. So this is, as you'll tell, this is absolutely a real team effort around all of this work, and I'm really pleased to be bringing I know we have regular updates on the JSNA, but this is a real point in time for us actually, and it sees them really bringing together some of the fantastic work that's been done. So there's a couple of things I was going to highlight, and then I'm going to stop talking because you don't want to hear from me. I'm going to hand over to colleagues to update you on all the work that's been done. But firstly, you'll see in the report we've updated, our JSNA encompasses a number of areas. Firstly, there's our specific theme-based JSNAs. So just to highlight that the pharmacy needs assessment, which is a significant piece of work, having done that twice myself, you know that it's a massive undertaking, and Alex and the team have pulled that together, working with Telford. We've pulled that together. So again, just a huge thank you to the team for pulling that together. Last time we came to the board, it was out for consultation. That's been finished, it was published, and it met the statutory requirements to publish that. So a massive thank you, and I point people to that. We will of course have to keep that up to date as changes to pharmacies, for example, might emerge, and we'll do supplementary statements around that. Just to highlight as well, for future boards, we'll be bringing back, there's some other theme-based JSNAs being undertaken at the moment. Drug and alcohol needs assessment, again, a requirement, but we were on that anyway. A brilliant piece of work there that's been done by one of Alex's team. So again, we'll be bringing that through, and children and young people's needs assessment, which we've been very passionate about getting off the ground for some time. So again, that work has started and feeds into our priority at the board around Healthy Start, particularly in children and young people, and into the ICS work as well. So I just wanted to flag those, and thanks to the team for pulling those together. So the two big bits of work today are is our broader JSNA. There's two things that we're going to talk about. I think there's the place-based JSNA, which we brought to the board pre-pandemic. We agreed a way forward with the board in terms of our 18 place-based JSNAs. Some of that work was paused due to the pandemic and has been restarted, and it's an absolute team effort. We've all got a passion around delivering place-based JSNAs, getting into our communities, understanding what matters to our communities, putting that along and speaking to our communities, most importantly, working with communities and partners in those areas, looking at the data and developing recommendations that meet the need, that will improve the health and wellbeing outcomes across our population. And it takes our approach around looking at wider determinants and a population health approach. So it's absolutely fundamental. And in a moment, I'll hand over to Penny and Hannah, who will update you on the work that's been undertaken in Highley, which is our first area that we've now completed the JSNA there, and we obviously want to bring to the board the report and get feedback on our first, what the profiles look like and input. The other bit that we'll come to then after that is Alex will talk about sitting alongside that is the web-based tool, which we're going to continue to add to, which we want to launch, and that we will is a fundamental tool for all of our place plan areas across Shropshire to start pulling that data together, and we'll continue to update that with information from partners and other organisations, bringing in our own local authority data as well. That is a fundamental part of the integrated care system population health management work. And so launching that today, again, is a real step forward, and we've talked, and it's, again, a joint piece of work, bringing in our insights team to develop that. So I think I'm just going to want to introduce it in that way, say a huge thank you. This is a massive team effort across colleagues within the council, across health, and across all of our partners and communities, most importantly, who are contributing to this. So I'm not going to say any more. I'm going to hand over I'm going to go to Penny and Hannah first, if that's okay, to talk about Highley and the place-based JSNA.
Thank you. Thank you. I wonder if it's worth, Val, the attachment, the profile document, Val, can we present it on the screen? I just wondered if, Alex, if you were okay just to give us a bit of an update over on some of the slides. Because
multitasking.
Yeah, sorry, Val. Just just to surprise you with that one.
Just bear with me.
While Val's doing that, we'll probably just do a quick update on how we got to the area profile, and then if Alex talks about a bit about the data, that would be really good. So this board agreed that we would have place-based JSNAs and that we would work through our 18 place plan areas. And because of recognition of what we already knew about the area, Highley was the first area that we looked at. It's been a bit of a guinea pig, but it's been a really good piece of work, and we're really pleased actually that it's an area that we've looked at first, because it's given us a lot. There's a lot for us to consider there and to go at from a working collaboratively point of view. So we've been working in the area with on the data. So Alex and his team have pulled together all the kind of health and care data, and then Hannah and her team have been on the ground in Highley talking to people about their views on their health and well-being.
Sorry.
Oh, it was good how it was. That was because it's not just because it's a PDF, so it will look like that, I think.
Okay.
Yeah. And then this area profile is a combination of all of that effort and work into one relatively short but useful document that kind of says this is what the health and well-being of the population, both in terms of the data and what we know from GP and hospital and other data and economic data and school data. And then this is what people say it's like to live in Highley. And when you put those together, this is what we think needs to happen in that area.
At last. Okay.
Yeah, so if we just scroll down, Val. Lovely, thank you. So those are the key facts. Alex, are you okay just to go through the first, like even if it's just the first 3 slides?
Yeah, sure. So basically the approach and the kind of remit here was to create a place-based evidence base to facilitate a place-based approach, place-based working. As a preliminary profile, we put together basically a kind of Tolstoy tome of evidence around health in Highley. It was extremely large and has some of the same problems that lots of needs assessments have, and lots of traditional needs assessments, which it was extremely unwieldy, very hard to maybe draw out the key messages which is required. So basically to draw in not only the traditional kind of hard clinical data or kind of quantitative data that is powerful but can be kind of narrow and a bit blunt, we wanted to draw in also the lived experience of people, and especially relating to the discussions earlier around stigma and the importance of the social fabric of areas, draw that together with traditional quantitative data, but also have that softer lived experience qualitative data. And rather than have that as an aside, which tends to be the case, to actually give it almost equal billing and bring it together into a kind of coherent and holistic evidence base. So you get this grander view of the population rather than this which can be a very deficit based, or look at the terrible rates of these diseases. Rather than doing that, having something a bit more holistic and a bit more community led as well. So if we scroll on to the next page, that's just some key facts around the Highley area. What we try to do, and it's a kind of difficult enterprise, is to take the breadth of the complexity of health issues and not just clinical outcomes, but also sort of upstream, the wider determinants of health, many of the things we've discussed here today, and try and bring those together in a way that was sort of rationalized and easier to understand, but could still reflect that complexity. And so this first page simply has 3 overarching themes. I think for those of us familiar with the indices of deprivation, they'll be familiar with those kind of broken down themes, as well as you getting this overall deprivation score for all the different areas in the country. You get this broken down score of income and education and health and crime. And we've tried to take a similar approach here. And we've segmented it into 3 overall themes, which align with the corporate plan for Shropshire Council: healthy people, healthy environment, and healthy economy. And just tried to do a simple visualization to say where Highley ranks in those terms. And what sits below this, if we scroll down to the next slide, is a number of subdomains. So within that healthy environment domain, where Highley tends to score quite well on the metrics we've used, You've got transport, mobility and connectivity, something we've discussed today, and is a mixed picture in highly. Housing and occupancy and environment. But in healthy people, you've got outcomes like education and learning and health, which is the kind of narrower clinical understanding of health, which don't do so well. And what it does here, this graphic, is compares by these different types of domain or different ways of understanding health, thematic areas. It gives us a way of comparing highly to the other areas and the other communities of Shropshire, so we can make comparisons, and it gives us an understanding of the actual health needs of that area. As we go through the document, if we go slightly further on, this gives rankings of the geography in question. We're using these place plan areas, which is a local planning designation, and there's 18 of those in Shropshire, and this gives the rankings in each of these domains for highly amongst all of the place plans of Shropshire. So again, in terms of questions of prioritisation and understanding relative need between our populations, this is supposed to help and give you an intuitive version of that. So in terms of housing and occupancy, if I can point that out in the green, it's ranked second for that, so quite good. But in the cost of living vulnerability, which obviously is pertinent to some of what we've discussed today, ranks very poorly. And that comes out of sub-factors and indicators and measures that sit below this. I won't get too technical, but particularly those concerning fuel poverty or rates of unemployment in the population and receipt of benefit rates, those sorts of things. So this is the kind of quantitative traditional data. And I can talk through a bit of what comes, Penny, and how we've integrated it into the focus areas, or do you want to talk about that?
No, that's great if you keep going.
Yeah. So, and in terms of going away from that hard data, obviously with my public health intelligence hat on, I love the hard data and all the kind of statutory returns and everything. But here, what we try to do is talk to the local population. So this is the results visualized of a local survey in highly, and what it plots along the two axes here is along the bottom, so from left to right, is what things people think are most important in terms of making somewhere a good place to live, and up the left hand side from bottom to top, it's what needs improving in highly. And what you see is they tend to go together, and that probably be because these things are prominent in people's minds. And obviously, if a particular area, if we all think about the area we live in, there will be things that are very prominent in our mind that are kind of strengths to the area and things we love about it, but things that are also deficits. And naturally, that will make you emphasize those more. I think you kind of, you notice what you don't have rather than what you have in a community sometimes. And what prominently comes out in the data, particularly prominently, is health services and perceptions around health services, activities for teenagers and public transport. And these can be grouped together and interrelate, particularly around, again, going back to questions of access and rurality that we spoke about earlier. We've kind of spoken about those later in, as we've broken those down into kind of disparate themes, but they tend to group together around those questions of access and isolation. And if we go on to the next slide, that's somewhat borne out here in specific questions around health, not just about the community and the place of highly as a place to live in, as a place to experience, but actually and specifically to the domain of health. So here you see clinical access and response as a very prominent answer in terms of things that need to be done and are just generally important in terms of health in the population, as well as mental health and those social isolation. So you can see there's these different themes that come out, but they are unified somewhat, perhaps, down the causal pathway, if you like, to questions of access and proximity to services, proximity to, the availability of leisure and things like this. And if we go on to the next slide.
Can I just come in there?
Yeah.
One thing I think is interesting there is that people perceive one of the biggest issues is for other people within the community is around lack of activity. So that's, you know, that's midway along. But for themselves personally, it's not an issue. It's quite low down. So I think that the community is recognising that others in the community need more activities, but not necessarily themselves. So I just think that, you know, it's just this kind of way of doing it is quite an interesting insight into people's thinking.
Yeah, absolutely. And I think that the differences between the two, where people think things affect them personally and what they see in their community, is quite striking. Likewise, again, with specific people, access to activities and facilities, again, mental health again comes up. Much smaller sample on this one because I think people, it's a more specific cohort in our population, so people have less kind of pronounced views, I guess, and less confident views about it. But again, some of the similar sorts of themes that are coming out. And then we come on to how these break down into specific areas of focus for Highley. So shall I carry on talking about this, Penny?
Yeah, I just wonder if Anne wants to come in there and just talk about the engagement exercise that we've done with stakeholders around those key themes. Are you happy to do that, Anne?
Thanks, Pen. So my team consists of 6 outreach officers, and what they do at this stage is they go into the community and spend quite a bit of time getting these surveys completed, and that can be through accessing community groups, working closely with voluntary community sectors, joining up with the markets, local markets, following the intelligence of the local town councillors and the parish councillors and members. So it can take anything from 2 weeks to 2 months, depending on the size of the town. And obviously it all depends on how much engagement they do get. As you can imagine, it's quite a challenge having a survey completed. I think we've all been there. We've all stood there at times where we've been asked to complete a survey. So it does take a skill to be able to really engage with the community and actually get that survey completed. So I think there's probably not much more to say at that. I mean, is it worth me just mentioning the figures around Highley and what we've picked up on?
Sure. So it's just, I suppose, just to say before you say that there's like 4 key themes that have come out, which have been in bold throughout what Alex presented there. So access to services and capacity there. Mental health has come out as well. So access to services, we've included in that the bus timetables, and there's definitely issues around that. So it keeps scrolling, Val. Yeah, so mental health, children and young people, and then as that we saw on the data previous that Alex reported on, cost of living crisis, so being one of the most vulnerable areas, and that's come out. So in that way in which Alex described of pulling that, giving equal status to the kind of what people are saying who live there and what the data says, these are the key themes. And so from that, we then have had a stakeholder event where Hannah and the team have worked to pull people together into one place to present this back and say, does this resonate with you? And if it does, what can we collectively do about it? We can't say, oh, Shropshire Council, it's over to you to do something about it, because we know that there isn't the resource or ability individually of organisations to do that. But actually, collectively, what can we do about that? So those kind of notes have been compiled, and the next step will be to put together an action plan around how we can address that based on what those wide range of stakeholders have said. Do you want to say more on that, Hannah?
Just to add that there are 2 stages with collecting the qualitative data. So it's actually an opportunity to complete online, or it can be completed on the ground. So for Highley, we managed to complete 48 on the ground, but with the support of the local parish council, we managed to push for 121 online. So it's just really interesting, I suppose, on preference of how people like to complete, but also that opportunity to have that support. So the staff will actually stand with the person when they're completing if they want, and have the opportunity to actually complete it on their behalf. So they get the opportunities to capture those conversations. So what we're also doing is making sure that we're recording any further conversations that are happening that can feed into this. So once the survey is completed, we then open it up to actually ask if any stakeholders want to feed in any further qualitative information. And that can be done by a quick interview, but we're going to judge that on each town area, so that may not happen in each town. It will just depend on what the community feel they'd like to feed in.
Brilliant, thanks. Alex, is there anything else that we should say?
no, not really. I think in terms of understanding needs in the population, I think what we've tried to do in terms of evidence is, rather than the traditional we're trying to affect health in a kind of newer, more asset-based, more community-led way and a more collaborative way. And I think what we've tried to do is reflect that in the way we've brought evidence together. And I think that's fundamentally from the public health intelligence point of view what we've tried to do.
Brilliant, thanks. So I guess for the board today, it's just sort of, we really welcome any feedback on that process, on what we've done, on the resulting report, on the format of it, but equally, if there's anything you think we've missed or anything else that as this was kind of the guinea pig area, as we go into new areas, are there other things that we should be doing?
Right, thank you for that. Does anybody have any questions or comments for Rachel, Alex, Penny or Hannah? Claire?
I think this is probably a good point to raise the issue about GP services in Highley. So board members will be aware that Highley Medical Practice have given notice of termination of their GMS contract. It was yesterday morning. So I think this gives us a real great opportunity, actually, given the information that's in the JSNA. The GP practice have to give 3 months, but they've actually extended that notice to the 31st of March. So we've got a good 5 months to work through what services we deliver. We've obviously got to find somebody to deliver the GMS contract, but I think there's some real opportunity to think about through the primary care network that covers Highley about what those kind of services look like that link back to the JSNA. And I know that we've already, even within sort of 24-hour period, have started having some conversations with partners, the local councillor, the MP, to really get into the nub of what can we do differently in Highley as we start to think about what the new GP service does and delivers for that population. So actually, I think it's almost quite an exciting opportunity. So, and just some reassurance to the villagers and the community around Highley that we're doing that. We're doing it quite rapidly and in partnership.
Thank you. Rachel.
Thank you for that, Claire. That's really helpful. And I think that kind of it nicely comes to the point I was just going to make, which you've said, is around what we do. Well, there's two things: what we do next and what we do with this. And I think, as I said, a massive thank you for everyone for pulling this together. This has been something we've talked about for an awful long time. And wanted to see. We wanted this. We knew that this was very resource intensive. I think Hannah's described. You know, you can feel it, but actually, it's absolutely invaluable. And those relationships that have been formed through the conversations, through the joint working, through coming back together as a stakeholder group to develop some recommendations for the area, will. And I think this will be the test of it in terms of the work, the practice around the practice moving forward, have developed. Not only have we got our evidence base, but we've also engaged through the process, and that in itself is a really important and powerful into working with our community. These are recommendations. This is not a JSNA Shropshire Council. It's a joint one, so it's not just for health and Shropshire Council. It's actually the vision for this was that it was a community understanding of the needs and issues within that community, developing recommendations collectively and collaboratively together that we will monitor, take forward, take action on collectively and collaboratively. And I think this is the first example of us actually being able and presents an opportunity to be able to do that. So, you know, I think we'd all welcome comments on the sort of presentation of it, because we want to roll this out, and the approach that's been taken, that's fundamental. But just to reassure the board, this doesn't sit on top. This is really important, and we don't want to do. We wouldn't want to waste people's time to do that. It should underpin everything that we do. It wants to be. It's a new way that we want to use that evidence base to inform and shape our services in the area. And this presents us with an opportunity to really do that and to listen to people and engage and do that collaboratively. It's just not. It's not. I think we came right back full circle. Not being done too. This is about doing this, working together.
Right. Thank you, Rachel. Any further?
I was just going to bring Alex in. I don't know, very briefly, if you just wanted to mention, we probably don't have time to go over all the detail, but the web-based tool, because all the data that Alex has pulled together and that goes into the report, we wanted to make sure that that was easily available and for the public as well. And so that work goes on alongside this and should make, hopefully, slightly the process of producing these more easier, but also transparent and accessible when we want to build that evidence base. So I'll just hand back to Alex.
Yeah.
Yeah, I won't show it on screen. previously, the board will have seen a hard copy or kind of a PDF version of this tool as a proof of concept. The beta version is live now. It's a link we can provide and people can explore for themselves. But basically, for context, the JSNA is a statutory duty that's discharged usually by health and wellbeing boards to local authorities. There is not really prescribed formal guidance on what you put in there, with good reason, but it's why most JSNAs look different, but there's a shared approach across local authorities generally in terms of the way that data is analysed and the way it's presented, and it's essentially static. So at the beginning, 10 years ago, when this was with local authorities, you used to get these very long, kind of arduous to go through 450-page documents that's, I mean, I'll speak openly, sat in a drawer somewhere. They were very worthy, but they had basically two central problems. It was difficult to get people to engage with them due to problems with the size of it, navigating the document, finding what they needed to find, getting information out that they would want to use themselves. And as soon as you print a document like that, it is necessarily the case that it will begin to reflect out-of-date information and evidence. And so it will present a potentially out-of-date picture of community need. Now, those things inhibit the use of data and evidence. So this tool has been developed in response to those kind of flaws with the old approach. It will be an online tool, basically broken down by theme. So a bit like the themes we've just seen in the local place-based needs assessments, where you can interact with the data and graphics. You can slice the data, if you like, into different cohorts or different geographies of interest. You can easily download some of the graphics that are in there, download the data yourself so it can be used for bids or repurposed for other analyses. And without being too technical, from a technical standpoint, it allows us to automate and bring in data through a sort of a pipeline that's established, allows us to sort of press a button, call the data from the Office of National Statistics or the Office for Health Improvement and Disparities or NHS Digital, and centralise it, work it into the correct format, and so it's immediately there for people to digest and use for their purposes. So not only is the analytical process one that's mercifully less onerous for us, but it also facilitates people in using the latest data that's available. Very briefly about next steps then. The immediate priority is to augment what we have so far in terms of health and social care data. Some of that will be from traditional sources like FOF and QOF, Public Health Outcomes Framework and Quality Outcomes Framework, hospital episode statistics, but also directly from enterprise systems within the health system, given issues with governance and protocols, but bringing in that data to do something deeper. So signposting to some of the deep dive needs assessments we've spoken about, which can be a specific cohort of interest in our population, so children with special educational needs and disabilities, or drug and alcohol abuse statistics, or pharmaceutical service need and access. We're planning on integrating those. We've got information around ambulance activity data, which might be of significant interest to the board, listening to the conversations today, especially around access and deprivation relating to rurality. And we'll bring some of what has been discussed and presented here into the tool. So cost of living will come in where we haven't done that already. Rurality, social isolation, and by centralising it here, hopefully that will allow us to have, again, an integrated picture of needs placed, and things like ambulance activity placed in the context of deprivation, in the context of rurality, geographical access, transport infrastructure, at local assets. And that's the purpose of this, to centralise, give a holistic picture and make it much, much more accessible and timely for people.
Okay, thank you for that. And I understand that the link to the tool has already been sent round.
I'm sorry, I got mixed up. No, I meant I misheard you, Simon.
Oh.
I've sent round the link for the cost of living, but no, I can send that link round.
Yeah, if you can send that link round.
Yeah, will do, sorry.
Thank you. Right, if there's no further questions or comments, I'll accept the recommendations provided unless members indicate otherwise, which are that the board is asked to note the update to work programmes and timescales. So happy? Yeah. Good. Okay, thank you. Moving on to the next item, which is the health protection update, and I'll ask Sue to take this item, please. And here we have Sue on screen.
Thank you, Councillor Jones. The update is a regular update to the board. We'll cover initially the health protection data and then the health protection developments for the system. So in terms of health protection data, I'm just going to cover the screening and immunisation and also the outbreaks, etc. So from a immunisation point of view, we have a flu vaccination programme in place, and this is alongside the COVID vaccination programme. This is going as expected, so no deviations. Moving on to shingles, we do have a lower than expected uptake, which we've mentioned previously, and AXA, that's the UK Health Security Agency, have cascaded a toolkit to our GP colleagues to promote increase in uptake. Childhood immunisations are always quite good in terms of cover for Shropshire. One area of concern, as you can see from the paper here, is measles, mumps and rubella. That cover has dropped off post-pandemic, and a process is in place to increase the cover. You will have had a full report earlier this year. But the actions that have been agreed are a communications paper with our primary care partners, because of course primary care take the lead on childhood IMS generally, and also assurances from our primary care partners that the uptake is being increased. There's also a national communication campaign, which you may be aware of, which is being led by UK government. So happy to take questions on that. Screening, there was some delay in screening again because of the pandemic. The majority of screening programs are now back up to speed. We're a little behind on antenatal and newborn screening. That's a staffing issue, which is being picked up by our partners. And the breast screening, we have talked about in more detail in previous meetings. The screening was moved into Telford and moved away from the outreach locations. That situation is in place up until the end of this year. As far as our communicable diseases in population, we are seeing some increases in communicable disease, such as respiratory viruses. I'm sure we've all been subjected to that. And if I start to cough, it's because I've picked up a respiratory virus. But currently, flu isn't at a level beyond what we would expect it to be. COVID, we're still monitoring, and we are still supporting our vulnerable locations, our care homes particularly. However, we're not seeing increased numbers, so we're assured. There are changes in testing, which means that we're not always receiving the reports of COVID transmission, but we're assured that we are in a positive position in terms of COVID currently. TB, there is now in place a 6-monthly meeting with our partners across SAF, and processes are in place to be able to monitor and treat TB across the county. Monkeypox has really receded into the background, so happy to answer any questions, but it's not being raised as an issue at the moment, and the brucellosis we had previously is resolved. We're working with partners on avian influenza. Because there is an increased risk at the moment. We're seeing an increased transmission within the bird population, and you're probably aware that there was a notice to house birds put in place earlier this month. This means that if we do see transmission or outbreaks within the bird population, then our local teams, the food team and the animal team in environmental health particularly, will be dealing with this, and we need to administer prophylaxis to them via antivirals. We do have one-off processes, but we are working with our SAF partners to put a permanent process in place. So we've got a pathway on that. Foodborne and waterborne diseases, I mean, we always see these, but nothing of major concern. Our health protection strategy is in the process of being designed currently. Thank you to anyone who sent back comments. There will be an action plan that comes out of that, and that's the next piece of work. Finally, one other issue to mention, which isn't in the paper, but you may be aware that we're also working with local asylum hotels and putting in health protection processes, again with health partners to support those hotels. Thank you, Councillor Jones. That's the end of the report.
Thank you very much, Sue. Does anybody else have any questions or comments for Sue? Yeah, Kirsty.
Thank you. It's just one thing you did mention about next year with breastfeeding. Obviously, because I had a couple of comments from residents, I'm a local down in Bridge North. Will it be returning? Do we know? If you find out, happy to send it over to me. That would be great.
Yes, yeah, I'm happy to investigate that. The message that we've been given is that the processes will return to normal once the backlog has been resolved. But I will come back to you because we need to check with our NHS partners.
Thank you.
Are there any other questions or comments? No, well, thank you very much, Sue.
Thank you.
And if there are no further questions, I'll accept the recommendations provided unless members indicate otherwise, which is that the board is asked to note the contents of the report. Thank you, so noted. Right, now moving on to the next item, which is air quality update, paper for information. So the papers for information has been circulated and published. Does anybody have any questions at all for Toby? Have we got Toby?
No, Toby's it's not here, it's just for information.
Oh, so it's just for information, right? Okay, so you know, we'll accept the recommendations provided unless members indicate otherwise, which is a further update to be provided at future Health and Wellbeing Board meetings. So that is the final presentation. I just have my chairman's updates. So we've received correspondence from NHS England Primary Care Support about changes of ownership for the pharmacies in Church Stretton and Ellesmere. The correspondence will be attached to the minutes of this meeting. The Shropshire Pharmacy Needs Assessment was published following the last meeting. Telford and Wrekin Pharmacy Needs Assessment is out for consultation. Val will circulate the document to board members after this meeting, asking for any comments to be received by the 7th of December. In the meantime, a draft response will be drafted and shared with the board with any additional comments from members added, with a response date of the 14th of December requested for the final submission. This will enable a response to the email back to Telford by the deadline of the 21st of December. The safeguarding annual report has been deferred to the January meeting. So I now thank everybody for attending the meeting, and the formal meeting is now closed. But if I could ask members to please remain in person or online after the meeting for the regular post-board session. Thank you very much.